Start with the next session. Please take your seats. So it's my distinct honor and pleasure to introduce next speaker. It's Dr. Guang Cheng of the Fred Hutchinson Cancer.
Oh, your microphone.
A pulmonary consult. Is it off? Okay, so once again, good afternoon. My distinct pleasure to introduce Dr. Guang Cheng. Dr. Cheng is the head of the pulmonary critical care consult service at the Fred Hutchinson Cancer Research Center, University of Washington. And her particular area of focus is complication after hematopoietic stem cell transplantation, bronchiolitis obliterans, and related diseases. Dr. Cheng as well pioneered and spearheaded the recent momentum, the multidisciplinary effort where pulmonologists and transplanters are working together in readdressing the difficult problem of lung graft versus host disease, specifically bronchiolitis obliterans. And she's the first author of the recent ATS research statement paper that just came out earlier this year. And she's as well the leader of the consensus effort that's going to be taking place over next year very intensively, taking another look in the team effort at the diagnostic criteria of lung GVHD, early detection, better approaches to understanding pathophysiology and therapy. And we look forward to hearing some of this today at her presentation. So thank you for being with us.
Thank you, Steve, so much for that kind invitation. It's wonderful to be here at this conference. Really lovely to be invited. What Meredith and her parents have done is really fantastic. And it's also cogent and interesting to come after the wonderful panel of speakers that you've already heard. And I'm hoping to hopefully address some of the issues that came up in the opening case discussion. But really my goal today is to, there's not enough time to review every aspect of the clinical science of early detection and treatment, but to present some of the work that I've been doing with my group and to see how we can actually leverage that into a treatment approach and possibly clinical trial approach. And then just also by way of, the theme of multidisciplinary care, I'm pulmonary critical care trained, and I actually didn't come to GVHD until about 13 years ago when I joined the Fred Hutch and the University of Washington. It was, I actually came from the University of Pennsylvania for my fellowship, and it was the one position that was actually open. It wasn't my intended specialty, but I fell into it. And I have learned so much, and it really does help being embedded in the cancer center and being side by side with the transplanters and other subspecialists. And, really coming to a conference like this is really important for me as a subspecialist to learn about GVHD. I view my role as, part of the support team to get patients into a good period of survivorship, but it is also the problems that we face are relevant for pulmonary medicine and for medicine at large. So just by way of introduction, late onset non-infectious pulmonary complications occur in a significant number of allotransplant patients, about 20%. And so this was a study that was done in Europe by my colleague Anne Bergeron when she was in Paris at that time, and it encompasses BOS, which is right now the only formally recognized manifestation of lung GVHD, but there are also other forms of late lung disease, such as organizing pneumonia, other ILDs, and issues that affect the chest wall and pleural spaces that are due to GVHD, such as the truncal sclerosis that we have heard about. Now, what is this like in the PT-Psi era? Probably much less, but we have to continue tracking this. And anecdotally, I will say that I have seen some bizarre manifestations of lung disease that come up maybe unexpectedly and not necessarily a usual context. Like I've seen lung disease, parenchymal, as well as airways disease without any other GVHD manifestations, which is generally fairly unusual. So just to anchor this on a patient perspective, okay, these are patients with lung disease who I have treated. These are quotes from their mouths. I need to breathe to live, but I also need to live to breathe. I'm still alive, but I've had so much loss. If I had known I would get lung disease like this, I would rather have died of my AML. So this is the kind of thing that, you know, hematologists may never hear from their patients, especially if they, you know, go off into the community. But I think it's devastating to hear that, in particular, that they would have rather have died of their cancer than to suffer from lung disease, because it is the one thing that really, really is so morbid, so difficult to treat, and what causes a lot of suffering. So my group, we did a patient survey to understand, across 3 institutions, to understand what patients really wanted us to focus on as transplant and pulmonary researchers. And it was interesting that early diagnosis and prevention came out on top in 54 respondents. And so in response to that, you know, I convened my group, as Steve mentioned, to bring together a critical mass of pulmonologists who are seeing these problems, and transplant docs like Greg Yannick, for example, at the University of Michigan, who's a good colleague, to really review the literature and to come up with a roadmap on how to tackle this, because I think we all agree in this room that early detection is probably a major key to preventing long-term morbidity. So just briefly, as a way of review, what interests me really, and what we need to understand in order to implement early detection, is to understand natural history or disease evolution. And that means understanding what the trajectory of disease is. And it really is heterogeneous. So you have people who will decline quickly, but once they get diagnosed and get on treatment, they will improve. People who will plateau, and people who will continue to decline. For the most part, the pattern is one of relatively rapid decline over 3 to 6 months. And this is assuming, this is an approximation because we have limited data, because a lot of people don't get their 3-month PFTs. And there is generally this observation that there is stability, but there's long-term kind of low-level decline. But there are definitely these phenotypes. And our window of opportunity for early detection really is in that period that we're actually not measuring, which is the several months before that, where you have a steeper rate of decline. So, and as other speakers have mentioned, we want to preempt that irreversible fibrotic phase. So this is the current NIH recommendation for PFT screening after HCT, like I mentioned. And you know, for high-risk patients, you want to definitely do it a little bit more frequently. The question is, and the challenge, the clinical challenge is, you know, how do you identify who's at high risk? Is there, you know, other than GVHD, which is sort of a loose category? Okay, is the frequency actually adequate, you know, every 3 months, or is it too much? You know, this is a challenging thing, might be challenging for people to implement if they have to if they have to do this so frequently. Is there actually access to a PFT lab? A PFT lab is slightly resource intensive because it requires a technician, a specially trained respiratory technician who can coach a patient through a measurement. And do the transplant doctors actually order the PFT? And I will tell you that it is shocking it is shocking that less than the fact that we did this survey, that less than 50% of transplant centers actually follow these recommendations in any form. So getting back to this notion of who is at high risk. Okay, so we know that patients with GVHD get BOS, so 14%, at least that's the pre-PTSI epidemiology. And it is usually recognized within 6 months of the initial onset or recognition of extrapulmonary GVHD. Spirometric decline at day 100 is associated with future development of BOS, and that gets at the notion is, okay, first of all, is the pathologic process actually starting there, or is this indicative? It's probably indicative of the risk that is accrued during the early period that puts you at risk for further development of GVHD when you get chronic GVHD or other insults. And then this history of respiratory viral infection, this has been shown retrospectively in lung transplant, okay, where BOS also occurs. And we have shown it retrospectively in 2 studies. And very recently, this is almost very hot off the presses, we finally just published our study conducted at the Fred Hutch from 2009 to 2014, an observational study of respiratory viral surveillance in allotransplant patients, and did find a significant association of early infection with respiratory syncytial virus and the development of BOS. And this was very, very clear, as you can see in this hazard plot. And then PIV, parainfluenza virus, is associated with late pulmonary impairment that doesn't meet the definition of BOS. So as I mentioned before, there's lots of other things that can cause lung disease other than BOS that also cause significant morbidity. So hot off the presses that it's not just respiratory viruses, there are specific respiratory viruses that confer risk. And with what we know about RSV and airways diseases in other contexts, like in children and asthma, not super surprising, but now we have the evidence that demonstrates this. And then I did conduct a pilot study where we did do this, we were monitoring at-risk patients with patients with GVHD with home spirometry and symptomatic RVI testing. This is my medical resident, Mike Vo, who worked on this. And we had patients send in self-collected viral PCR for viral testing, and this was actually conducted, the majority of this was conducted during the COVID era. Other than rhinovirus, the most common respiratory virus detected from the nares in a symptomatic episode was actually SARS-CoV-2. And in our preliminary analysis, we are showing that this is the hazard ratio of actually going on to develop BOS is over 3, though there are wide confidence intervals, and this is a limited population. But there is increasing evidence that there are specific viruses that confer increased risk. Okay, back to the idea of how do you actually make an early diagnosis? Again, right now with the tools that we have, this requires routine interval PFT. And it's not just doing the test, it's also the interpretation of the test and being able to look at the longitudinal trends. So rather than go by a cross-sectional time point or a cross-sectional value of FEV1, such as what is proposed in the current NIH definition of an FEV1 of less than 75%. What you really want to look at are trends, okay? Trends in the decline rather than the specific threshold. And as a pulmonologist, for me, a 10% decline is a good rule of thumb where you might want to pay more attention or consider the diagnosis. So when in doubt, repeat the PFT. And I don't wait 3 months, repeat it like next month, okay? And also I wanna mention, so just apropos of the case that was presented this morning, in addition to the RV, the residual volume, you do wanna look at the total lung capacity, the TLC. I think we home in on the RV because that's what's written in the NIH guidance. But the TLC, the total lung capacity, is really important to contextualize the RV elevation and the spirometric declines, because the other lung diseases that we see, such as interstitial lung disease or pleural effusions, can present more in a restrictive fashion, and that's where you need the TLC. Okay, what are the types of spirometry? So this is, I know a lot of patients don't enjoy PFTs. You go from supervised, where you're going to a lab and you have a technician coach you through the measurement, blow, 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 to unsupervised, where you have a handheld device and you could do it in the privacy of your own home. And what I've been exploring is whether wireless home spirometry can be a screening modality. Can we bring more frequent PFTs into the home, make it more comfortable for patients? We now have this cloud-based technology where the devices are Bluetoothed, and they can be recorded and actually reviewed in real time. So we did do a little pilot study where we enrolled patients with chronic GVHD to do weekly home spirometry, and we were able to find that antecedent decline can be indeed detected, and those are indicated by the little red triangles of different PFT trajectories. So I just wanted to also show you the modality that the little platform that I'm using right now. And I want you to focus in on the flow volume loop, that little curve. Okay, and this is what is available now. So this is like me looking at my smartphone with the app and my coordinator, who's gonna coach me.
Okay, starting effort 3.
Okay, so look at the loop. And so it only takes a couple of seconds. And it's easy. It goes off to the cloud. You do it 3 or 4 times, and the team looks at it, or we get sent an alert if something goes wrong. The patient is sort of coached through it electronically if they don't do a good measurement. So that's how it works. And so I use this technology in a prospective study involving 3 centers, including Michigan and Stanford, to examine whether or not what exactly are the spirometric changes that predict the development of BOS. So what we did was we enrolled patients with chronic GVHD, before, without a lung diagnosis, and we asked them to do weekly spirometry for a year, as well as their routine 3-month PFTs and symptom questionnaires. And if there was a consecutive decline in their home spirometry of greater than 10%, then there was a letter that was sent to them and a letter that was sent to their provider without any, the provider, it was up to them to decide what to do. We did enroll a cohort of patients who were newly diagnosed with BOS to actually follow them as well to see what their post-BOS trajectory was. But the endpoint for the first cohort was a clinical diagnosis of BOS, which included the NIH definition, other complications, the respiratory viral infection, which I just showed you, and also to acquire a biorepository. So right now, so this is being prepared for publication at the moment, that we completed our enrollment period and our last follow-up in April of 2024. We got 133 patients, 113 in the at-risk cohort. There were a lot of early withdrawals and a number of people who passed away. I mean, this was a fairly sick population. But at the end of the follow-up period, there were 20 individuals who were diagnosed with BOS. And interestingly, there were quite a handful of other diagnoses, including organizing pneumonia, infection, sclerosis. These are people who had restrictive impairments and infections. How does the home spirometry operate, and will patients do it? What's the adherence? Incredibly, the adherence was pretty darn high, even for participants in cohort 1 who don't yet have lung disease. 77, the median was 77% of the expected weekly measurements were performed. Of course, there was a range. Cohort 2, these are patients with BOS. They know they have lung disease, do slightly better. So overall adherence was really very high, almost 80%, which is quite incredible. But this is also facilitated by the fact that the app gives you automated text reminders every week. We get patients to make it a habit. It's kind of like brushing your teeth. It's like the thing you do, Sunday afternoon. Okay. A good proportion, a good number of patients provided over 90% of their measurements. And then, there were certainly participants who didn't want to submit any, and those are patients who just, if they, and actually within the first 3 months who's going to be what. If they are not going to do it within the first 12 weeks, they are simply not going to do it, and we take them off study. And then also there are many reasons for non-adherence. People get sick, they get hospitalized, they lose their spirometer, the dog ate it, things like that. So we also wanted to look, it's really important to understand if it's accurate with your lab PFT, okay? The Pearson correlation for the FEV1 is really very high. And these are patients who are coached in the beginning, okay? They're not new to PFT. There is sort of a training period. People get better with it over time. There is a bias, at least in this study, I used a different spirometer, a bias, which means, it's off the mark by a certain amount, acceptable within ATS standards, but really what we're looking at is the so-called intra-class correlation. Very, very high, greater than 0.9, and what that means is, is it consistent longitudinally across time? Can you trust the trends in what a patient is doing over time? And with a correlation that high, that is, so it's reliable. The trends are reliable reflection of what's actually happening in that patient. So Maddie Peha, who was a medical student at the time, now a pediatric pulmonary fellow at Seattle Children's, she looked at this data and this really clever thing of visually mapping out the longitudinal clinical course of someone by their home spirometry PFT, their lab PFT, their symptoms, as well as their respiratory viral testing. And so you can see this is an example of somebody where the blue line with the little dots, that's your home spirometry. They were pretty good with their home spirometry. The green is the laboratory PFT every couple of months. The X on the top dotted line, those are each time the patient submitted a viral PCR. On the bottom X-axis are the symptom scores. And then the dotted red line is the 10% threshold for concern. Okay, and so you can see that this individual did get, their home spirometry did dip. It correlated with their lab PFT. They had a viral infection, okay? A red X is a positive test. And then the vertical dotted line is actually when the BOS diagnosis actually occurred. So this is someone, they had all this stuff going on, but were not actually formally diagnosed with BOS until quite a bit later. So this is a very busy slide, but just to show you that the BOS in this cohort it was pretty mild to moderate in severity at diagnosis. So in the subgroup, in the group that had detected home spirometry detected antecedent decline, the median FEV1 was, hovering around 70%, not super severe, but that meets the definition, the NIH definition. There was a group where they were diagnosed with BOS, but there was never this 10% decline that was detected. And it's interesting to note that this group, at diagnosis, at clinical recognition, had, almost normal FEV1. Like their FEV1 impairment wasn't particularly severe. So I think this reflects that in the 3 centers that we conducted this in, that people are doing their PFTs and their doctors who are looking at the measurements and being like, okay, I'm not waiting until the NIH diagnosis. I think this is BOS, okay, based on other criteria. So anyway, that's just something to note about the particular cohort. But when we looked at the subgroup that did have antecedent decline, it occurred like 5 or 6 months prior to the formal diagnosis of BOS. So there's this massive lag time, okay, even after you've detected FEV1 decline. And then if you are only doing PFTs, if you ignore the home spirometry, then the lag time is about actually 3 months between first decline by lab PFT to BOS diagnosis. So this brings up a number of different points. So actually I want to just show this is some examples of the BOS with antecedent decline that was that we found antecedent decline by home spirometry, that sometimes the decline was detected and then BOS occurred. And then in this, the upper left is the one very, very severe and classic case of BOS that, yes, we recognized him early and he just continued to decline in spite of everything. And then for those who did not have an antecedent decline recognized by home spirometry, it's interesting that in many instances, the decline happened after BOS was clinically recognized. And so it's interesting that, these people generally got on some degree of therapy, or that the BOS was mild. It probably had happened months before, and now somebody's looking at the PFTs and being like, oh, this person probably had BOS and it probably happened, 3 to 6 months ago and nothing's changed. And so whatever they got on because of for their GVHD stopped it, or the process was just not going to progress, okay? So lots of caveats. Non-BOS lung disease also show similar home spirometry trajectories, and this is a case of organizing pneumonia where you can see the trajectory is like, quite similar to that classic trajectory, and then the organizing pneumonia got treated, the lung function did not recover, and this is a case, and actually we see this with some, not infrequently, got converted to BOS. And this gives you, supports the argument that there are probably cases of organizing pneumonia that represent lung GVHD. And then truncal sclerosis with restriction on the PFT can also look very, very, very similar. Okay, so then we looked at whether consecutive decline could be used as an early biomarker for BOS. So we looked at this greater than 10% on 2 consecutive measurements. And what we found, we were looking at the restriction of declines within a specific time window prior to clinical diagnosis. And what we found is that if you it got a little bit that if you increase the number of declines, it was less sensitive but more specific. Okay, and that probably accounts for the fact that there's weekly variation in your PFT. And then, does a lesser degree of FEV1 decline, is that actually more sensitive? Yes, but much less specific. And then, when we looked at the positive predictor value, it's actually not very high. It's actually quite low for NIH diagnosis of BOS for FEV1 decline. So what do we do with this information? I mean, we think it should work, but my conclusions from this are that weekly home spirometry are feasible. It is accurate in somebody who is willing to do it on a weekly basis. FEV1 decline occurs months prior to formal BOS diagnosis, that the declines are sensitive but not specific. We have shown also that less severe or indolent BOS is increasingly recognized. Non-BOS lung diagnoses are common, and really that we probably need to refine how we define the biomarker rather than it being consecutive. We have to account for the variability. And that at this moment that you can use home spirometry, I think you can use it for screening and somebody who's willing to do it and do it on a regular basis. So we're trying to build on these findings with RV-BOS study, which is longitudinal monitoring and lung function with the colleagues that I mentioned. And then just briefly mention the other modalities that have been mentioned in other talks, parametric response mapping, these quantitative CT methodologies that can look at, these are better for cross-sectional assessments, look at air trapping indices that would be otherwise hard with the naked eye, and other toolbox techniques, hyperpolarized xenon MRI, forced oscillometry, nitrogen breath washout that are being investigated by the pediatric group, the Transpire group, and other adult groups. So very briefly, since we're running low on time, that a couple of words about treatment. Okay, so we know that the lung response is almost always worse than other organs, therefore a different approach is needed. And I want to posit that the goals of therapy, that we have to move beyond nihilism. I think we can move beyond nihilism, that the goals of therapy really should be to restore lung function as much as possible, okay? And not be satisfied with it just being stable, okay? We do want to prevent further lung function decline, and we want to preserve quality of life, okay? And that is a patient-centered goal, and every patient, needs to have this discussion with their provider about do they actually, what the pluses and minuses are. So yes, we want to target the chronic GVHD pathways, including fibrosis. Not a lot of good evidence, but I want to point out that there is one RCT that actually shows an improvement. That is the use of inhaled corticosteroid and long-acting beta agonist only. Okay, the FAM trial did not show that. The FAM trial just showed stability. Okay, so, but what I do in my clinic is I usually use FAM with the bronchodilator plus minus prednisone, and now there is a choice of the other FDA-approved agents. There's been a smattering of clinical trials that have come out. So, as was mentioned before, in a previous discussion, the risks of systemic immunosuppression we know from prednisone, and I also want to remind people that azithromycin was associated with a risk of hematologic relapse and malignancy in a randomized clinical trial. So, and does this question of does upfront immunosuppression change FEV1 trajectory? And we have been looking at this in our prospective cohort, and with almost 100 patients prospectively followed where they got FAM or FAM plus immunosuppression of any combination, prednisone, bel, ruxolitinib. It seems like IST maybe does a little bit better, but not by too much. and that the people who tended to be started on immunosuppression were those patients who had a lower FEV1 to begin with, probably more symptomatic. But if you looked at both groups, FAM or FAM plus IST, at the end, at 12 months, a third have improved a little bit by 5%, a third have declined by greater than 5%, and a third are right in the middle. So really, it's this is where we are at with our therapy, and it's impossible without a randomized clinical trial to actually know whether your systemic therapy is efficacious in the long run or not. Okay, so I'm going to propose in my last minute a stepwise approach for early BOS that leverages this home spirometry data, that we should have an adaptive approach where, particularly for early disease, where it's really mild, the patient's not symptomatic at all, they're like, I feel totally fine, give them a home spirometer, start them on ICS-LABA, have them do their home spirometry. If they progress, and you will know this within the first 4 to 6 weeks, if they progress, bring them back in immediately, start them on prednisone, FAM, and whatever new agent that you have in trial, or the next line therapy, okay? If they are stable or improved, so a third, you should expect some to actually improve. They continue on with their ICS-LABA. If they get a complication or they decline by their home spirometry, put them back, get them back into your systemic therapy arm. And then just want to mention the pulmonary antifibrotics, pirfenidone. This was just published for long-term use, and there was a new agent out that was just FDA approved, nerandomist, a PDE4 inhibitor that is much more potent than this, that I think we should be considering for our patients with BOS and other fibrotic GVHD. So the take-home message is early detection is improving, much more needs to be done. It should be coupled with evidence-based treatment, and we've outlined some research objectives in this statement. And I want to make a plug for this multidisciplinary approach. I think this is just a theme from today. We have organized a consortium around this topic, and would be very happy to hear from anybody who wants to learn more about GVHD or come to our research conferences. So acknowledge all the people that I work with and the patients, my funding sources. Thank you. Okay, lung transplantation. Yeah, we chatted about this last. Okay, so end-stage lung disease from BOS, yes. What are the indications for lung transplant? They are going to die within 2 years, but it's their only organ system. They have to be on less than 20 milligrams of prednisone a day or the equivalent. Like, not a lot of other stuff going on. Have good social support and have the potential to rehab. You have to have a BMI of greater than 18. Like, you can't be losing weight, which is tough because the sickest patients cannot get there. Yeah. And each lung transplant program has its own kind of aggressive, threshold for jumping on a patient. I actually have a patient who probably went to lung transplant today because he's young, he's 24 and has no other organ problems from, other GVHD.
I have a question. First of all, of course, fantastic presentation because give us hope, that we can really have path forward. One comment, 2 questions. One comment, just this budesonide beta agonist studies enrolled much better patients than FAM.
Yes, it did. That's right, because in France, they do their PFTs every 3 months religiously. Patients don't complain, they all do it. So the median FEV1 into entry of that trial was 65, whereas in FAM it was 48.
Right.
Yeah,
So it's hard to,
right.
but, and then two quick other questions. One, half of your patients with BOS didn't meet NIH criteria for BOS. I'm just curious, how did you make diagnosis of BOS for those? And the other one is that your diagnosed patients with BOS were fairly early, mild or maybe moderate. Did you have any indication that they did do better on treatment than you would expect for BOS?
Okay, so the first question, how did we make the diagnosis of BOS if they didn't meet NIH criteria? So it was basically, it was done at 3 centers. For me, it's if they actually have a more than 10% decline from their immediate prior or their baseline. There's evidence of obstruction. There's some subtle things on the PFT beyond the scope of this lecture that I look at, okay, that having to do with like the lung volumes and the mid-flow rates, a compatible clinical scenario, and any CT findings of air trapping. So if you see air trapping, which often is like an early sign, it's very subtle. Then it's like, well, okay, you don't have anything else. And sometimes you bronch these people and they don't have any parenchymal stuff. My colleagues at Stanford, they are using PRM. They are actually using PRM to diagnose BOS now, if they don't meet NIH criteria.
Okay.
Yeah, and also, I mean, Greg Yannick, he's the PI of the PRM study at Michigan. They're also sort of on top of that. So, and also there's atypical criteria where you have symmetric decline in your spirometry, the FEV1 NFC, without a change in your total lung capacity. And that is actually a known phenotype for airways obstruction that is well described in COPD. Okay, then your second question was...
Or just those who were diagnosed, they were pretty early, so did you have any indication that they're doing better?
Okay, so I haven't done the deep dive into those particular 20 patients, but when we looked at the entire cohort of patients also that were enrolled into the BOS cohort in that ATS analysis, there really wasn't a correlation between, sort of a little counterintuitive, your level of FEV1 and your overall trajectory at 12 months. It was equivalent. I mean, it didn't actually change. So, we're waiting on more patients, and we got to do a sort of deep dive on, what did that have to do with? But I will say that there is a response, there is an early response that is often ignored at 1 month. Okay, this is why all the clinical trials where they say, okay, don't monitor until 3 months. I disagree with that. I think you should actually, I always have my patients come back within 4 weeks. And they do feel better. Some of them actually feel a lot better just on the inhaled steroid and beta agonist.
Okay, thanks.
Dr. Cheng, there is a question online for you. The question is, could you discuss your criteria for adding an antifibrolytic?
Oh, for adding an antifibrotic. So the antifibrotic we have at hand right now, pirfenidone and nintedanib, I would add it, number one, if people cannot tolerate the prednisone, ruxolitinib, or belimumab, and if there's sort of evidence of decline, or if they're in this chronic phase where they're like, I don't want to take those immunosuppressive medicines and I want to just feel better, then I do start them. I have some long-term patients with FEV1 of 30, 40%, pretty impaired, who have started on it and do actually feel better, which is what we showed that the Stop BOS trial showed. It's not for everybody because you have to take a lot of pills and then there's GI side effects, but it still needs to be monitored. Yeah, I think the new one that is just FDA approved, that is promising. That is probably more promising than the pirfenidone, but it's not gonna work overnight, unfortunately. It's just, those agents definitely people have to be patient with.
Wonderful talk. Any concern regarding conditioning regimens with subsequent risk of BOS?
Really good question. We've never really been able to parse that out, though historically busulfan has been identified as a risk factor. The Hutch data, not able to replicate that, but that has been shown at least a couple of historical studies. TBI is a risk factor for early acute lung injury, but we've never really been able to show that in the BOSS cohort. And in fact, like early acute lung injury is not really a robust risk factor for BOSS because those patients often don't survive long enough. But if there is some indication of lung dysfunction, it's probably reflective of something that happened or the toxicities of the conditioning regimen. Yeah.
Just for pirfenidone, since you had mentioned it as an alternative to some of the immunosuppressive options, do you see them as exclusive? Could they ever be used together? I know there's no data, but just
yes.
Do you see it as only being a one or the other?
Well, actually, I mean, pirfenidone in combination with something like ruxolitinib would actually be, sort of make sense biologically. And what I didn't show is that in the STOP-BOSS study that my colleague at Stanford did, there were actually responses in the skin. There were good responses in the skin long term. To Emily's presentation, there wasn't there wasn't like a distinction between the fresh skin GVHD and sclerosis. I suspect that it probably helps some sclerosis.